in adrenals from our Campbell lecture series. So for today, we'll focus slowly on adrenal surgery. So for the first part is the open surgery. So open adrenalectomy can be broadly classified into transperitoneal and retroperitoneal approaches. Transperitoneal approaches into the anterior transabdominal and thoracoabdominal approaches, in which the main advantage lie in excellent surgical exposure and better access to the hilum and great vessels, at the expense of higher risk of intra-abdominal organ injury and ill use. In contrast to the retroperitoneal approach, which includes the flank and posterior lumbar dorsal approaches, which results into a smaller operative field but are associated with less ill use and shorter hospitalizations. In addition to the retroperitoneal approach, it's ideal for those who are morbidly obese, in which whom the abdominal panniculus will fall forward in a flank or prone position. So for the first part, let's start with the flank retroperitoneal approach. So the position, the patient is placed in a lateral decubitus position as seen in this picture, with the side of the adrenal pathology up. The table is flexed at the level of the costal margin, and a kidney rest is employed to maximize the distance between the costal margin and the iliac rest. An axillary roll is usually placed under the axilla, with the arm closest to the table extended, secured on an arm board, and the upper arm is slightly flexed at the elbow and placed on an elevated armrest. The lower leg is flexed and the upper leg straight with pillows placed between them. All the bony prominences should be padded. So the incision, the course of the 11th rib is palpated, and the incision is made along the rib. So along the rib, not under, not over. So along the rib. The latissimus dorsi, external and internal oblique, and transversus abdominis overlying the rib are divided until the anterior surface of the rib is exposed. So this is an additional. So usually it's also prudent to do a rib excision. So how to do it? The anterior periosteum of the rib is scraped off using a periosteal elevator. And the periosteum on the upper superior and inferior aspects of the rib is visualized. The periosteum posterior to the rib can be scraped off in a similar manner with the periosteal elevator, taking care not to injure the neurovascular bundle. After stripping the periosteum from the tip of the rib back to the paraspinal muscles, usually you cut the 11th rib with the rib cutter. Then the rib stump is then smoothed with rondure, and hemostasis is secured with the aid of cautery or bone wax. Once it's open, the retroperitoneal space is created. The lumbodorsal fascia is entered, and blunt dissection is used to dissect the peritoneum of the transverse fascia anteriorly. The muscles are divided, and the plane between the gyrotrophic fascia and the peritoneum is identified. In this picture, this is a laparoscopic view. So the gyrotrophic fascia is already dissected here, reflecting the peritoneum anterior-medially here. The plane within the diaphragm and the retroperitoneum is then developed, facilitating an entry to the retroperitoneal space. Once the peritoneum is fully mobilized, the vena cava, as seen in the picture, or the aorta, can be visualized depending on the side. For the dissection, again, this is we're talking about open surgery, but this is a picture, a better view laparoscopically. On the right side, dissection typically starts with the division of the peritoneal layer overlying the vena cava along the medial border of the gland. The plane between the medial surface of the adrenal gland and the lateral vena cava is then bluntly dissected to expose the adrenal vein. The adrenal vein is then isolated with a right angle instrument, or you can use a mixture forceps. The vein is then ligated with silk ties or surgical clip. The adrenal gland, again, this is a picture using a laparoscopy. The adrenal gland can be dissected at the start with its superior attachment, care must be taken to handle the friable adrenal glands surrounding the adventitia to avoid spillage, seeding, or autotransplantation. The actual arterial branches to the gland are usually not identified but safely cauterized during dissection of the glands. Clip and tie should be employed if any vessels are identified. The inferomedial attachments to the kidney are then taken with sharp dissection or cautery and free the adrenal gland. And then it is removed from the surgical field. The left, same thing, except that the aorta is encountered and the left adrenal vein runs along the course, typically originating from the renal vein. So for the closure, after ensuring good hemostasis of the adrenal bed, the surgeon closes the incision in 2 layers with a running loop polydioxycinone suture, and the deeper layer consists of the transverse abdominal and internal oblique muscles, and the outer layer consists of the external oblique and muscle and the fascia. So screen closure may be used with staplers may be used or absorbable suture. So take note of this because most of the closure will dwell into a 2-layer closure with a deep layer and outer layer mostly. So we're done with the flank. So now we're going to discuss the posterior lumbodorsal approach. So this is the most direct route to the adrenal and no major muscles are divided. Thus, dissection required to expose the adrenal glands. The prone position allows ready access for both adrenal glands through separate incisions. However, surgical exposure is limited. So usually for posterior lumbodorsal approach, it is reserved for smaller tumors or bilateral adrenal hyperplasia. In addition, access to the renal vein and great vessels is more difficult, which may be problematic in the event of excessive intraoperative bleeding. So this approach should not be used for large tumors or adrenal carcinoma, large adrenal cortical carcinoma. Okay, so for the position, so this patient is in prone position after intubation with the table flex at the level of the 12th rib. Pillows are placed under the abdomen and the lower limbs, and care is taken to avoid compression in the eyes of the patient in the prone position. So next, the incision. So there are 3 incisions here. So the patient is positioned in a prone the patient is positioned in prone. The incision is made along the course of the 11th and or 12th rib or a hockey stick, as you can see here, and the left side of the patient. Because I said left side because this patient is in prone. So progressing downward and outward in a curvilinear fashion up to the level of the 10th rib, extending over slightly below the 12th towards the iliac crest. So take note of this incision. Okay. So after skin incision, division of the subcutaneous tissue and the latissimus dorsi and sacrospinalis muscle in a layer exposes the 12th rib. The sacrospinalis is retracted medially and its attachment to the 12th rib. Subsequently, division of the lumbodorsal fascia and then the posterior subcostal ligament releases the pleura from the 12th rib. The pleura dips below the 12th rib in the region of the costovertebral angle and may be perforated if the rib is elevated. So the 12th rib is also excised, same as how I described it earlier. So it was mentioned also here that the 11th rib should be retracted upwards to expose the retroperitoneum. If bilateral procedures is undertaken, as you can see in this picture, this is a bilateral adrenalectomy. There's a thing that is called a phenosceto retractor. So this is it. So that can be used to assist in bilateral exposure. So it looks like a spinal retractor. For the dissection of the adrenal gland, the division of the final hepatic attachments and the adrenal gland and the vena cava in that position, I'll go back, is visualized. So that's the liver. So in the right adrenal vein is identified at the posterior lateral region and it's ligated with clips or ties. The arterial branches are also ligated, and the adrenal gland is mobilized posteriorly away from the paraspinal muscles, and it should be dissected out superiorly and progressing caudally. So that's for the prone position or the posterior lumbar. So next is the transabdominal approach. The anterior abdominal approach is indicated in cases of large and potentially malignant tumors for which adequate exposure for extensive dissection is needed. Also, it is mandatory in cases of inferior vena cava or extensive nodal involvement. The anterior transabdominal approach may be attempted through subcostal, chevron, or midline approach. So, subcostal, chevron, and midline. Uh, the subcostal or chevron incision provides a better exposure of the superior and adrenal and lateral aspects of the adrenal gland than the midline. The midline approach is generally reserved for cases in which extraadrenal pheochromocytoma is suspected along the great vessels of the pelvis. So if you're going lower as low as the pelvis, a midline incision is recommended. So for the position and incision, the patient is supine with the body roll placed under the back of the level of the costal margin to accentuate the position of the patient. Then the skin incision is made 2 finger breadths below the subcostal margin, extends medially to the midline. The external, internal, and transversus abdominis, external oblique, internal oblique, and transversus abdominis are divided laterally, and the rectus muscle and sheath are divided medially. The peritoneum is entered with sharp dissection. So the approaches for abdominal, for the anterior transabdominal approach are this: the gastrocolic ligament, through the gastrocolic ligament, through the iliorenal ligament, through the transverse mesocolon, and the lesser omentum. So basically, these are, as discussed last Wednesday, these are the openings to the adrenal gland. Ernest, nakalimutan ko i-send yung password pictures. The linear-renal ligament, the line of Told, is incised and the descending colon is mobilized medially. The splenic flexure is then taken down by dividing the splenocolic ligament. As you can see in this picture, so this is the splenocolic ligament. So at the bottom of this is the white line of Told, so it should be opened from the left colonic flexure, or in this case, the splenic flexure. So subsequent division of this and the opening of the retroperitoneum along the inferior border of the pancreas will allow superior retraction of the spleen, as you can see in this picture, and the pancreas with exposure of the left renal vein. So as we go deeper, the left renal vein should be identified as it courses downward the inferior medial border of the left adrenal gland into the left renal vein. It is ligated and divided. The medial attachment to the aorta can be taken at this point either with monopolar or a long angle instrument with the harmonic scalpel while applying gentle traction. The lateral and inferior attachments to the kidney are taken by blunt and sharp dissection of the renal capsule, taking care to avoid the vasculatures of the upper renal pole. So for the closure, it's the same 2-layer closure. Deep layer consists of the transverse abdominal muscle, transverse fascia, internal oblique and fascia, and the posterior rectus sheath. The superficial layer is the external oblique and fascia, and the anterior rectus sheath. So now let's proceed to the right adrenalectomy. So after the peritoneum is entered, the hepatic flexure is mobilized inferiorly and the liver is retracted superiorly. The Cocker's maneuver is performed to mobilize the second part of the duodenum sharply, and the inferior vena cava is exposed, as you can see in this picture. So you retract this is the retracted second part of the duodenum. So the rest, the extraction of the adrenals is same as that of the left side as discussed earlier. So the difference is for the right, you do a Cocker's maneuver. Next, for the thoracoabdominal approach, this offers the best surgical exposure for the retroperitoneum. So as I've read, it's technically still retroperitoneal. The adrenal gland and great vessels may cause this one more morbidity, such as incisional pain, pulmonary morbidities, phrenic nerve injury during division of the diaphragm, and the need for a chest tube. This approach is generally reserved for large invasive tumors with extensive involvements of the surrounding structures of the vena cava that cannot be safely removed via the transabdominal approach. So this is useful in right-sided tumors because the liver and the inferior vena cava usually they limit the exposure, whereas on the left side, the spleen and the pancreas can generally be elevated to provide adequate exposure. So the position. So the position, the patient is placed in a semi-oblique position at an angle of 45 degrees. So the table is placed upward, and the opposite side is in a decubitus position. And a body roll, as you can see here, is placed longitudinally along the hemithorax and the flank to achieve and maintain this position. The ipsilateral arm is placed across the chest on a padded armrest, and the other arm is secured to an armrest. So for the incision and dissection of the adrenal gland, the incision is made along the 8th or 9th intercostal, extending from the posterior axillary line, curving over the costal margin to the abdomen. So it's shown in this picture. So if you orient, this is the intercostal 8th and 9th rib. So the incision may be in between and or. So this is the latissimus dorsi is already exposed. And then the medially the rectus muscle. The latissimus dorsi, serratus anterior, and intercostal muscles are divided as shown in this picture. The costal cartilage is then divided with cautery, and the incision is carried through the anterior and posterior rectus sheath and the rectus abdominis muscles. The pleura is entered along the superior margin of the rib to avoid injury to the neurovascular bundle. And the lung is packed away. So the pleura is, as I mentioned, is open. So here, the surgeon must not cut directly to the center of the diaphragm because the phrenic nerve can be damaged. Marking the sutures can be placed on either side of the diaphragm to aid alignment during closure. Once the diaphragm is divided, so we're going to use the same retractor, the Finucchietto self-retaining retractor is placed. The rest of the dissection similar to the previously described technique. So the dissection is basically the same because in this position, the patient is, it's almost a retroperitoneal position. So the closure is a bit tricky for this because a chest tube should be placed and the diaphragm is closed with a running or interrupted suture using a non-absorbable one. To take tension of the diaphragm, the rib should be reapproximated also with interrupted sutures, but with chromic or any absorbable suture. So the suture should also be placed in the costal cartilage to bring the costal margin together. So followed by the closure of the serratus anterior and the latissimus dorsi. Remember, you also open the posterior part of the rib and thorax. So again, a chest tube should be placed, water sealed and with suction. So we're done with the open adrenalectomy. So for the second part of my discussion will be laparoscopic adrenalectomy. So for laparoscopic adrenalectomy, a transperitoneal approach can be performed with the patient in supine or lateral position. So in general, the transperitoneal approach is greater working space for better visualization of the operative field and surrounding anatomic structure than with the retroperitoneal approach. The lateral transperitoneal approach allows for a greater working space as in gravity aids in moving the bowels away from the surgical field. In supine, the advantage of supine that it permits bilateral adrenalectomy. However, the more dissection and retraction of the surrounding organs are generally needed in supine position. So the supine position for lap is reserved for bilateral adrenalectomy. So for the positioning, after general anesthesia and NGT and catheter should be placed, or urinary catheter should be placed to decompress the bladder and the stomach for the NGT. The patient is either positioned in a lateral position, full lateral position, with the operating side upward, or a modified 45-degree angle. The table can be straight or minimally flexed to increase the distance between the costal margin and the iliac crest. Care should be taken to avoid excessive flexion because they may lead to neuromuscular problems. Excuse me. For the port placement, so in this picture, so the initial 10, if you nakikita may arrow, it's either inserted, you may use an open technique or with the aid of a Virus needle. After insufflation with the CO2, 2 or 3 other trocars are inserted under the vision of a camera. So a 5mm port is placed at the anterior axillary line. You can also use a 10 or 12 for larger instrument for easy retrieval. And then the splenic flexure may have to be mobilized before insertion of this port. So this is the third. So you can add an additional fourth port with the 2 to 5mm port to aid in dissection and retraction. So you can do 4 port also for lap. So for the mobilization of the colon and the spleen, so let's talk about the left side first. The line of thought is incised and the colon is mobilized inferiorly. The splenocholic and lineorenal ligaments are then inserted towards the diaphragm in the level of the gastric cardium, allowing for full medial rotation of the spleen away from the surgical field. And care should be taken to avoid injury to the stomach and the diaphragm at this stage. So sudden loss of pneumoperitoneal pressure with increase in ventilation pressures may may signify diaphragmatic perforation. So with the spleen rotated away and the tail of the pancreas dissected off, the left adrenal gland will be exposed once you retract the spleen and the pancreas. Next, the left renal vein is then identified, as you can see in this picture, and traced along its superior border to reach the point of entry within the left adrenal vein. Next, the mobilization of the adrenal vein. So it is carefully isolated and ligated, as you see in this picture. So also, it's also advisable to put 2 clips on the patient side, as you can see in this picture. So next, care should be taken to avoid any upper pole branch of the left renal artery to be injured. It is so important to recognize that the inferior phrenic vein may occasionally join the adrenal vein before its entry into the left renal vein. The adrenal arteries is supplied. The adrenal artery supply is divided with either cautery or harmonic scalpel. Grasping on the adrenal gland should be taken to avoid the gland. It is fragile and usually it tears easily, leading to intraoperative bleeding, even if you already ligated for the artery and the vein. So for the closure for laparoscopy, once the adrenal gland is freed, it is placed on an endoscopic bag. You can remove it with the 10mm or if you use a 12mm port. So the pneumoperitoneal pressure is reduced, and then the 5mm and the surgical bed is inspected for hemostasis. So all port sites larger than 5mm are closed in layers with fascial approximation and skin closure. So next, now we'll proceed to the transperitoneal lateral approach. So for right adrenalectomy, the port configuration for transperitoneal laparoscopic of the lateral part, an additional, so from what I mentioned earlier, 2 or 5 millimeter port sited is site most superomedial. That is should be used, this one, for retraction after creation of the pneumoperitoneum from here, from the 10 millimeter port. The first step to mobilize the liver is by dividing the triangular ligament laterally and inferiorly. So this is for the right side. So the liver is then retracted, as you can see here, from the triangular ligament using a 2 or 5 millimeter forceps. And then the lateral parietal peritoneum is grasped by the forceps, creating an assisted self-retaining retraction of the liver. A Cocker's maneuver is then performed to mobilize the second part of the duodenum. This permits the visualization of the inferior vena cava and the right adrenal gland. The short right adrenal vein can be identified as it joins the vena cava. So the rest, as described earlier, and also same as how I described in the open transperitoneal approach. So next for lap, we proceed to the retroperitoneal approach. So we're done with the lateral, the transperitoneal, lateral, and supine. So next is the retroperitoneal approach. So for this, it can be, for retroperitoneal, it can be done, also be done in the patient in prone or in lateral position. The main advantage of this is for the peritoneum, it avoids complications, visceral complications, and bowel injuries. In the absence of pneumoperitoneum, hemodynamic and respiratory morbidities is also reduced. The retroperitoneal adhesions from previous surgeries may also be avoided, or the colonic injuries are also avoided. So for the retroperitoneal adrenalectomy, we'll first start with the left side. So the patient is placed in a lateral position with the left side up, with the kidney rest under the body, and the operating table is flexed to accentuate the flank position. So a 1.5 incision is made near the tip of the 12th rib. So this is the 12th rib. The underlying muscle and fascia divided with the cautery until the lumbosacral fascia is visible. The lumbodorsal fascia is then inside sharply, and the finger is inserted to confirm access to the retroperitoneal space. So the inner surface of the 12th or 11th rib should be palpated superiorly, and the iliac crest inferiorly. So usually, same siya ng retroperitoneal ng kidney surgery. So we just feel for the tip of the 11th and 12th rib. So we can easily free from the lumbodorsal fascia. So usually we do blunt finger dissection. So next, once you free that, the balloon dissector may be used along the posterior abdominal wall in a cephalic direction. And then the psoas should be identified. This landmark this is the landmark for a longitudinal orientation. So a balloon tip trocar is secured into position and is in this space and is insufflation. So you place there your 10 millimeter port, and then an additional 5 or 10 is placed about 2 finger breadths above the iliac crest. So this one. Next, the ligation of the adrenal vein. So again, double shaping, as seen in this picture. So small arterial branches arising from the aorta is also ligated, either with clips or harmonic, or the harmonic. So be careful with be careful with the inferior phrenic vein that may course along the anterior medial border of the gland, usually joining the adrenal vein. So it's a tributary. So for the right side, it should be performed in a similar fashion, dissecting cephalad along the inferior vena cava to reach the renal hilum and right adrenal vein. So almost the same. So actually, that's it for adrenal surgery. I just want to add some points for for partial adrenalectomy. So these are the indications of partial adrenalectomy. The difference is that the adrenal gland is exposed but not mobilized to preserve the arterial and venous supply. especially in cases which the main adrenal vein has to be sacrificed. So patients after bilateral adrenalectomy, usually they have a poorer quality of life. So kaya option din tong partial. So aside from that, usually we should know the complications. So there are two, usually intra-op and post-op. So for the intra-op, usually access related for lap or either with open. So usually bleeding or hemorrhage, ischemia, and injury to the neighboring organs as a result of thermal injury with incorrect plane of dissection. So depending on your access. Also, for patients with pheochromocytoma, they may exhibit hemodynamic instability. For post-op complications, usually for post-adrenalectomy patients, usually the primary aldosteronism, Cushing syndrome, pheochromocytoma, and the generic ones such as bleeding, pneumothorax, pancreatitis, pneumonia, and ileus, and other intra-abdominal fluid collections. So that's it for my lecture. So basically, just different approaches, but same procedure for adrenalectomy. Usually the access will be different for lap, and the incisions and positions are different from open surgery. So do you have any questions regarding this topic? So it's very straightforward for adrenalectomy. So this is additional for the lecture of Dr. Yado last Wednesday. Kunti lang pala tayo. So if we don't have any more questions, we'll have an attendance. So, iba na. Rai, kaya mo mag-picture?
Sir.
Okay. Kamusta, sir? Mukhang enjoy na enjoy dyan.